Good afternoon. We're on the final leg of our two-day journey on the the meeting here this afternoon. I think we are at item 21. I think Mrs. Bush, we are, do we have you up? The primary care physician data? Oh, no, that's, Libby, come on up. Thank you. I didn't have you down. And thanks for the documents that you prepared for us, but you're up, and then we'll turn it over to Mrs. Bush. So thank you.
Mr. Chairman, members of the task force, my name is Libby Miles, Associate Research Analyst at the Legislative Service Office.
Libby, can you just pull that really
Absolutely.
closer than you're even comfortable with, please? You don't have Senator Taft's voice.
Mr. Chairman, I can do that. In front of you, you have item number 21-1. This memo provides a brief background on primary care and reviews several state-based primary care physician incentive initiatives, but is not necessarily an exhaustive list. I believe we got a lot of information from our WWAMI and WICHE representatives just before me. However, I will briefly go over some of our loan repayment programs within the state. So prior to the current loan repayment program that we have now operating, we had the Wyoming Healthcare Professional Loan Repayment, which is in statute currently. However, it has not been funded since 2016. It was originally funded through general funds as well as tobacco settlement funds, and it authorized loan repayment for physicians and dentists for $30,000 per year with a 3-year commitment. To our active program is the Wyoming Loan Repayment Program, very similar name, and it provides educational loan repayment to physicians and other healthcare professionals practicing for 2 years at a federally designated health professional shortage area in the state. The maximum award for the 2026 program year will be just over $34,000. Mr. Chairman.
Thank you, Libby. Your comment on the loan repayment program that we haven't used since 2016, that loan repayment program for primary care physician, is that language specific to education repayment?
Mr. Chairman, correct. It is specific to physician loan repayment, but just physicians. It does not specify primary care.
Okay, I guess and the reason I'm asking and mulling stuff around, noodling's the word of the day, noodling stuff around, is Mrs. Bush's comments yesterday on the challenges of primary care physicians establishing their infrastructure to practice outside in a private setting. And I'm wondering if we could perhaps expand or amend that current program, Madam Chairman, to provide loans if we don't get in trouble with 16.6 somehow. But anyway, just a note to self and Anna that we might see where we get in trouble there.
Absolutely, Mr. Chairman.
Please proceed.
Okay. I will now move on to the surveyed states. So I will begin with Idaho. So Idaho has the Physician Incentive Program. It assists in paying educational debts of physicians who practice primary care specifically in medically underserved areas of the state. It provides up to $100,000 over a 4-year period. And this program is funded through a rural physician incentive fee, which is paid by students in programs such as WWAMI, those who are receiving state subsidies for their medical education. The fee statutorily may not exceed 4% of the average financial subsidy a student receives from the state for the participation in such program. The state matches that fee at a rate of $2 for every $1 assessed on the student. Priority is given to physicians who have paid the fee, so the students in the state who participated in WWAMI, followed by Idaho residents prior to completing medical school, and lastly, physicians from other states who were not originally Idaho residents. 85% of participants in establishment are still practicing in Idaho. Moving on to Montana. Montana has the Rural Physician Incentive Program, again, very similar to the one we just spoke about in Idaho. This one awards physician practicing in medically underserved area with a maximum of $150,000 over a 5-year period. So any physician is eligible, not necessarily just primary care. It is also funded through an annual fee paid by students in programs such as WWAMI, but their fee may not exceed 16% of the support paid by the state. For the 20.
So give me an example of that. Please tell me how, so we're assessing a fee to they are assessing a fee to the student?
Correct, Mr. Chairman.
So walk me through that a little bit. Give me numbers that I can
I gotcha.
land or math can understand, please.
So, Mr. Chairman, for the 2026-2027 academic year, the annual fee is $6,220, and that is on the student.
Okay, so that would that then be similar to like our WWAMI program then on the portion that the student's responsible for?
Correct. This is the
Okay.
portion that the student must pay.
Okay, got it. Thank you.
Priority is given to applicants who have paid the fee, and there have been 287 participants since establishment in 1991. 51.4% of the program's participants are still practicing in the state. Additionally, Montana has the Graduate Medical Education Council. It was created in 2011 under the Montana Office of Rural Health. They make recommendations regarding physician workforce and coordinate financial support for graduate medical education, also known as residencies. In 2011, Montana had 7 primary care resident physician positions, and in 2026, Montana had 43. Moving on to North Dakota. North Dakota has a healthcare professional loan repayment program. Physicians receive up to $20,000 per year for up to 5 years for working at a selected healthcare facility. These facilities are required to commit to provide half of the agreed upon loan repayment amount. On to South Dakota. This is likely the most robust program out of the surveyed states. South Dakota has the Recruitment Assistant Program for physicians practicing primary care in rural communities with a population of 10,000 or less for a minimum of 3 years. Selected physicians are entitled to, yes, Mr. Chairman. Okay. Selected physicians are entitled to an incentive amount equal to twice that of University of South Dakota's medical school in-state resident tuition. The amount beginning on July 1st, 2026 is $258,702. Rural communities are responsible for providing a portion of payment at certain rates depending on the community's population size. These rates are found at the bottom of page 9. They increase as the community's population increases. Since establishment in 2012, the program has had 78 participants. Mr. Chairman, I can pause if you had a question on that.
If we could come back to North Dakota, those 5 bullet points at the end where it says physicians are selected utilizing the following criteria. Does that align at all with the comments we had with the University of Wyoming and Senator Baldwin on identifying and selecting funding based on the need? I mean, are they selecting these folks? Do they, if there's a specialty that there's a need for in the state, then do they give a priority to that specialty? Am I seeing that correctly?
Mr. Chairman, correct. That is how I interpreted that, yes.
Okay.
It
Thank
just
you.
gives the program flexibility to adjust to the needs of the state.
And so we're seeing legislative influence there depending on the needs. Thank you.
Okay, Mr. Chairman, lastly, we have Utah, and Utah operates the residency grant program. This provides eligible facilities with a grant to create or expand residency programs within the state. The program awarded $1.5 million in fiscal year 2025. There were 4 new residency programs have been developed, 3 of which are for primary care specialties. And with that, Mr. Chairman, members of the task force, I'll stand for your questions.
I'd really like you to come back. I thought one of the most important parts of this memo was on page 2. If you'd take us down on understanding primary care, how that's defined, and then their income compared to others. There's a challenge. We're concerned about people going into primary care, and if you could just kind of go through that section there and note the differences in depending on the practice.
Sure. Mr. Chairman, members of the task force, primary care is defined as the provision of integrated accessible healthcare services by clinicians who are accountable for addressing a large majority of personal healthcare needs, developing a sustained partnership with patients, and practicing in the context of family and community. How primary care specialties, some people include certain specialties and some don't, but more generally, it includes family medicine, internal medicine, pediatrics, OBGYN services, and occasionally geriatric services as well. The primary care population or physicians entering the workforce is decreasing, and I believe our Wyoming Medical Society provided me with some information regarding why that may be. There's a plethora of reasons, some of which include the cost of education compared to the cost or the average salary that those practicing in primary care receive compared to those who are in hospital services or more surgical procedural services. You can see the breakdown of the national mean annual wage of primary care specialties on page 2, but these are generally lower, like I said, than those other specialties that operate in a hospital. And then other reasons may be for the rural area, as we've heard about last meeting, is the low patient volume and then having those brick and mortar operations as well.
So if we were, in your research, if you were an individual pursuing a medical degree and were really, where are the higher paying disciplines in that field? I think you're implying that primary care is on the lower end. So how does that compare with some of the other disciplines, and what are they?
Mr. Chairman, I don't have the exact numbers in front of me on comparing exact salaries, but again, those more procedural, so surgical based practices, as well as I believe it's in here, especially procedurally heavy or hospital based. And yeah, if I hear from the Wyoming Medical Society would like to jump in. Yeah.
Thank you. Thanks, Mrs. Bush. Can you shed a little light on that?
Mr. Chairman, yes, I'd be happy to. So our averages that we have for primary care range from 298,000 to 330, depending on what source you look at and what their practice environment is. Average specialty range is from 417 to 516 when you take an average of them. But when you look at specialties individually, so neurosurgery averages between 750 and 875,000, cardiothoracic 690 to 900,000, orthopedic surgery 611 to 733,000, plastic surgery 554 to 637,000, cardiology 575,000 and up.
So Sheila, if I may, when we had the university here just before lunch, Mr. Smith noted that 172 out of 284 WWAMI students were practicing back in Wyoming, which constituted about 60%. But the next paragraph said of that 172, there's currently 123 still in practice. So that kind of brought my ears forward a little bit. So I'm thinking rather than 172 out of 284, it may be more like 123 out of 284, which is only 42%, if you're tracking with me, unless some of those that constituted the 172 were people that just retired, aged out, or something to that effect. And my question is, those that aren't practicing, are the majority of them primary care docs? Is there one doctor that's leaving the profession earlier than others?
Mr. Chairman, I don't have the answer to that question. It's also interesting when you look at WWAMI data, they do a really nice job of calculating their return rate, which is that initial return rate. And then they also do another calculation that is post 3-year obligation. Both of those numbers are usually pretty impressive and continue to demonstrate the value of WWAMI. I don't know that I've seen a breakdown by specialty. I know that we track the match each year at the Medical Society, those students who've graduated and where they're matching. Last year, so the 2025 graduating class had an unprecedented number of students matched with family medicine, which we were all really, really happy about. Interestingly, a number of those graduates actually had their strongest interest in obstetrics, but were very nervous about their ability to come back to Wyoming and practice OB. And so they chose family medicine with the idea of maybe doing an OB fellowship to be full spectrum family med in the event that they could come back and still be part of the maternal health care workforce. But that varies year by year. So I think in 2026, we didn't have near the number of graduates pursue family medicine. I think it was far more specialty heavy this year.
Thank you. But for the two of you, the reason I'm asking that is based on the good information you provided yesterday, that our challenge is getting those individuals to go into that practice, which is a practice that we desperately need throughout the state, and trying to figure out those barriers, and was hopefully trying to see what other states, how that was impacting them as well. So that's the reason for the questions. Thank you. Please proceed.
Mr. Chairman, I'm ready to stand for any questions.
Any questions for Libby on this one? Thank you. Thanks, Libby. Oh, did I miss somebody? No. If I'm missing you, by the way, just holler, please. Okay, Mrs. Bush.
Thank you. I really appreciate this agenda topic being put back on the radar for everyone's consideration today. I continue to believe that a strong primary care workforce, is this loud enough? It's really loud, will be an integral part of Wyoming sustaining healthcare in our state into the future. It really does serve as the foundation of healthcare. Without primary care, our specialists don't have referrals. They really are the front door of healthcare and a vital component of the health of our state. Interestingly, primary care handles roughly half of all patient visits in America, yet receives under 5% of every healthcare dollar that is spent. That gap of investment shows up directly in the pay gap for our physicians and what they live with every day.
But so then why is it dry? Why is that? That doesn't make sense to me. If they're producing that volume and receiving that much, so help me understand why that is.
I think it's multifactorial. I think it's the reimbursement rates for family physicians. So
Determined by?
Insurance and the Medicare and Medicaid rates.
Okay, thank you.
Unless they're employed, and then it would be a salary, there would be a component of salary to that. There are a variety of different employment structures. Some of them are a flat salary and then volume is on top of that. So it'll be a fairly low salary. And then their payment annually is a calculation of their patient visits. Like those two things combined create their annual salary. Obviously, if an independent clinic, it's a much different structure. I think I touched on it yesterday and we'll continue to talk about it a little bit today. You have a real problem in how medicine is paid, in that we have a structure that does a really good job of pricing procedures and we're much less adept at valuing the time, judgment, prevention, and continuity that's involved with family medicine.
So I thought your comment just then was really interesting, that you noted that we have a very good procedure, a very good method of identifying cost procedure. But we heard in day one the challenges with that, which may be in conflict with. So I guess I'm asking, is that an opinion, or do you think there's factual? And it's okay if it is just opinion, but I just see it conflicting with that conversation yesterday.
The conversation remind me of the context.
When we got into the charge master and how are we billing out costs, and that would come back to procedures in what is that based on? And I think we can, or at least I drew the conclusion that that's complex at best and hard to determine what those costs are based on.
Mr. Chairman, I think that is true. I think when I say we are good at, I think I mean, we're good at taking one procedure and treating it like a widget and giving it a value for that procedure being accomplished. It doesn't mean it's simple. It doesn't mean it's not complex, but primary care works so much differently than a procedure. They don't produce widgets.
Okay, thank you.
I don't feel like I've satisfied you. I think you're
No,
moving on.
you didn't.
I know, I can tell.
You didn't, because I think that I'm still, I think that was the argument yesterday, and I don't think the fact, because you didn't satisfy me isn't a fault of yours. I think I'm still struggling with that whole process that our hospitals have been trying to navigate on having a basis to do that, and it's just not. I realize it's just not as simple as it sounds, and so I was just trying to fish for a little help there and see if you. But so please proceed.
I think you have help from two other
Please.
folks here.
Just to kind of weigh in here a little bit, and we've had this conversation with some of our payers. No matter how the salary structure, whatever it is set up, whether it's a base salary plus RVUs, relative value units, based on productivity, it still comes down to what's reimbursed. And we have created a system where these specialists are rewarded much more than our family practice providers. And we've had conversations about maybe trying to bend that curve a little bit to incentivize more to go into family practice. And so I think Sheila's doing a great job of explaining that. But the reality is we build a system where primary care physicians are valued less than anesthesiologists, orthopedic surgeons, or whatever it might be, and it's system wide. And part of it, that's because they generate more revenue potentially or whatever. But we've had conversations where we think, for the last several years actually, where we think we should change the way that that payment methodology and the amount that we pay to primary care physicians has a higher value, because in reality, in the grand scheme of things, it should be valued higher.
Okay, thank you. That's helpful. Please, Karen.
I'm not trying to, my brain hears that it's a perceived value. I mean, you can't, there's not a production. So when I go see my nurse practitioner, it's a counseling session in the sense of, here's my stuff, what are the things that we need to do? So there's not a product at the end that's measurable necessarily, like there is a spinal fusion where you can get all those widgets and account for it. The value of the expertise and counsel. I think the other thing that's interesting, as far as the PCP being seen as important as even patients, well, it's just my primary care. They're going to refer me out to a GI. That's not always true. So I think that not only does the system of reimbursement need to put more emphasis and priority on primary care, we want to educate people the importance of it as well. Because I think that some people, like, I'm just not going to go, and then they'll wait until they have an acute attack of some sort, and then they go seek care. So it's preventive in nature across the board. But I talk with her about all the things, and there isn't always a proof of production.
The deliverable. Very well said. Excellent. That was really good.
Mr. Chairman, one more follow-up. And
Please.
That's another great point. This is an interesting topic. But I think the other thing that we've seen is a primary care physician, a primary care provider 20 years ago looks quite a bit different than one does now. And a lot of that has to do with subspecialties. And so we didn't used to have intensivists. We didn't used to have hospitalists. We didn't have, and so primary care physicians used to have much, in a lot of settings, they cared for a lot more. They're ER docs, they're family practice docs, they might be delivering babies, all of those things. We've seen a shift away from that in a lot of areas. And so now they're more specialized in certain areas. And so again, you have to look at where the dollars go, but their role has kind of changed in the way that medicine is delivered in a lot of our facilities too over time.
So then would you suggest, Mr. Boley, because in talking to some constituents, some old retired CFOs at hospitals and stuff, would suggest that hospitalists have put pressure on the primary care physicians because now they often, as you refer a patient to the hospital from primary care, it's then taken over by a hospitalist. And so the value is diluted of the primary care guy who used to follow them up to the hospital to treat them. Is that a fair assessment?
Mr. Chairman, I think it's a fair assessment. Yeah.
Okay, please proceed.
Mr. Chairman, I would also say that that's accurate. And also, it can be true that those hospitalists saved our family physician workforce who were struggling to be all things to all people 8 to 5 and then rounding at the hospital. And so you had family physicians who were starting their day at 6 a.m., rounding at the hospital, starting their clinical practice at 8, doing that till noon, going back to the hospital from noon to 1, going back to their clinic, and then at 5, going back to the hospital, and then charting who knows when, and trying to have a family and hold a marriage together and be a human on top of all of that. And so I think that we can be, including my members, sometimes we can romanticize the time when a family physician could round on their patients at the hospital. Those patients were probably beautifully served because there was so much continuity in their care. Their family physician who knew them also followed them into that hospital episode, knew so much more about them rather than handing them off to a hospitalist. At the same time, those hospitalists served a critical role in being able to keep those family physicians in our community or in the workforce at all, because they were burning out real hard. Okay, thank you. So as I was thinking about this testimony and recommendations to give the committee, there are so many things that states are doing. I think that loan repayment and funding our program that hasn't really been in effect since 2016 is a really low-hanging fruit. It's sort of a no-brainer as far as I'm concerned in terms of a critical thing. I don't think that it's the big fix. When you really look at what the rest of the country is doing and how states are looking at this exact problem, they are creating, sorry, it's so close. They are creating councils, task forces, commissions, whatever you want to call it, and the variety of naming is entertaining. But you've got, I think, upwards, this morning I got up early and I counted 18 states in the last 5 years who have all, through legislation, created enduring bodies, sort of like this one, multidisciplinary groups to look at just primary care investment and what it means for the state. In June, I shared with all of you a graph that shows the United States healthcare spend that really, if you remember, there was a super tall bar graph on the left. It was in bright red. That was the United States healthcare spend. And all of the countries that are sort of calculated with us that kind of went across that to the lowest. And then there was a primary care spend line that was put on top of that. So all the way to the left, you had the highest spend in healthcare, which was the United States. And the dot representing our investment in primary care was almost at the very bottom of that bar. And as you moved from left to right across the graph, the spend decreased and the spend in primary care exponentially went up. So at the very end, I think it was maybe Spain, you had the highest spend in primary care and the lowest overall total spend in healthcare. And I think that's really demonstrative of why states across the country are taking this so seriously. So just for example, there is a handbook available that was written by the University of Colorado Anschutz, and it's a stepwise progression. And it says the first step is to stand up a multi-stakeholder task force or advisory committee. In Colorado, House Bill 19-1233 created the Primary Care Payment Reform Collaborative, which advises the state on defining primary care and setting the investment targets. Second step, build a shared data baseline before setting those targets. Virginia's task force on primary care spent its first 2 years just building better data. No spending mandate. That data alone was strong enough to win a $151 million increase in Medicaid primary care payments from the General Assembly in 2022. And then the third step, only at that point, legislate targets, payment models, and accountability. Colorado, Delaware, and Rhode Island all moved from an advisory committee and data to legislation and regulation in that order. And so I think I offer all that, and I would also like to share some of what these other states are doing. But I think it's to say today, in what Sheila Bush is able to research and provide, isn't going to get us to the best place. I think it's a continuation of groups like this one and maybe a formalization of an entity that can just study this, particularly around alternative payment models. There are a variety of options available. We have not unpacked all that goes into each of those, from value-based care to DPC to a state-run ACO or accountable care organization. There are a multitude of options. And I think it will take a group like this one through time to really find out what we want. But we have to start first with what the goal is and what we know today. So I think it's important to look at Virginia created the Task Force on Primary Care. Colorado has the Primary Care Payment Reform Collaborative. Massachusetts has a Primary Care Access Delivery and Payment Task Force. I think if I were to list all of those, there's maybe 15 of them, all named some variety of those words, all with a very similar goal, which is to unpack primary care, look at the workforce. Many of them ended with ultimately finding spending targets. So a mandate of a certain percentage of the state's healthcare spend being dedicated to primary care, or working and partnering with insurance companies to explore alternate payment models. And so I really feel like in addition to some of the, like I said, some lower hanging fruit that is available, more study and more conversation around this is probably required. But the first step is really educating the legislature and each other of the importance of primary care, and then following what some of these other states have done really well, which is truly unpacking what the state needs and then identifying those solutions together.
So, thank you. Sheila, as you're lining that out and suggesting continuing on and looking at the importance and the need and the placement of primary care and recruiting, I look off to your left shoulder and I see Mrs. Semino back there. And I just wonder if she were sitting up here. No, I don't need you to. I'm just using you as an example. And she was talking about mental health. Would she not be saying the same thing about those disciplines in the mental health field, psychologists, child psychologists, counselors, that, and so my question to you as a group like this task force considers the future of healthcare delivery in the state, is it right or wrong to look across disciplines collectively? I worry that we get all fired up and jump on the primary care horse and leave mental health or whatever other profession in the dust and look back and say, oh crap, now we got to go back and start over. So when you talk about this approach to primary care, is it, in your opinion, do we just focus on primary care? Should we look at collectively the needs of the state in access to health care? Is the question.
I hear you. Mr. Chairman, I think a couple of things can be true. I think that primary care gets the focus because of its direct relationship to cost containment. As the front door of healthcare, or where ideally the front door should be, there is a weight of evidence demonstrating that the more we invest in primary care, the better our health outcomes and the lower our overall healthcare spend. Mental health is unbelievably important and critical. And I think that, if there is any appetite to pursue something of this nature, a committee like this can make it whatever they want it to be. The value of this group and the 4 days that we have spent together, I think, has demonstrated how amazing it is when you get people together in a room who can share information, sometimes in a spicier fashion than others, but really get to the bottom of some of these issues. I would argue that it's very similar to what we had in the early 2000s with the Healthcare Commission, which I know that you're going to love that I'm mentioning. But I think that I have thought frequently throughout our time together that this has felt a lot like I remember the Healthcare Commission feeling in terms of the caliber of the conversation and the value of the data that was provided. And so I think that you can include mental health if you want to. The reason other states have focused first on primary care is because of its direct relationship with the goal of what this committee was looking at, which is the affordability of healthcare and how we make that more attainable to our residents. Okay. Other questions? Okay.
Mr. Chairman, thank you. In that research, who in those states or what entity in those states is gathering that data?
Mr. Chairman,
Do you know?
so in all of those states that have those advisory councils, who's gathering the data for the councils? I don't know that answer. I would imagine it's a lot like this committee's working, or the way the Healthcare Commission worked in the early 2000s in terms of a combination of legislative presence, private sector engagement, and maybe executive branch support. But I don't have the answer. I could find out.
Mr. Chairman, thank you. And I'm just thinking about doing something similar. What does that look like? What resources do we need? I know that our Legislative Services Office, particularly when it comes to this issue of data development, we could use some more resource there, which is why the Management Audit Committee has no real purpose, because we don't have the right resource to do programmatic audits, which is what it's supposed to be doing, for whether or not programs are effectuating their purposes, not financial audits of counties, but I digress. So, just if we were to put that up, would we need to put a resource into LSO, get more money that way? Is the Department of Health, I love it to be the source of all things, which due to the competency of that agency serves us well, but we may need more to put together a commission like this and to have meaningful data prepared to utilize for good policy. So just that's where that line of questioning was going.
Thanks. Mr. Chairman, I think that we could look at the way the Healthcare Commission was structured initially and each of its subsequent bills. So it was initially formed, I believe, in 2001 or 2 on a 3-year rolling sunset that just continued to get renewed. And every time the legislature revisited that structure, they tweaked it a little. And so you could go back to the 2009 bill, which was the final sunset that passed out of the House unanimous. There was a great deal of support for the Healthcare Commission and its continuation. It went to the Senate committee, and one individual wasn't as fond of it and put it in the drawer. It wasn't given a vote in the Senate. And that was the end of the Wyoming Healthcare Commission. And so I think it's worth visiting that, but it's worth looking at that 2009 bill and where they got, because we have experience in this state over 8 years or whatever it is, of where we started and how each of those 3-year periods, how it got tweaked and modified, both with how it was supported, how it was staffed, who sat on it, what its goals were. Its goals changed through time. When it was first initially created, it had a real strong eye toward tort reform. That was taken out completely, I think, in its first iteration of being, renewing the sunset. The other exciting thing is, as of Tuesday, in the Rural Health Transformation Fund and the commitment from the state and the Advisory Council to do a GME council, which was mentioned earlier. Wyoming does not have one yet, and it soon will, hopefully, with this funding support. There's a lot of opportunity there, I think, for us to look to. Okay. The other things that just fall as recommendations would be to strengthen graduate medical education and GME capacity. I think, again, we're starting to check that box, and all of us can sort of breathe easy and put it at the bottom because we have this GME council in the works. And so to to give that the space and time that it needs to do what we hope it will do. Expand physician recruitment and retention incentives. So the loan repayment program, which I've mentioned, there are states who offer tax credits to physicians practicing in rural and underserved communities, which may have merit if we look into that a little more.
What tax would we give them credit for?
Mr. Chairman, that's a great question.
Okay.
Don't know, because we don't have an income tax. I'm not sure what that looked like or if that was only applicable in states with an income tax. Recruitment incentives tied to service commitments in shortage areas. And then the things that I mentioned yesterday, a sort of a financial and structural operations support for independent and community-based physician practices. So like I said, those potentially low-interest loans or some sort of a structure that can work as an incubator for physicians who do want to open an independent practice but really are overwhelmed at even the idea of it. With that, I would stand for questions.
Mr. Chairman, we were just talking about what taxes there might be, and I think there might be corporate taxes or business taxes that if they set up a clinic where they employ multiple physicians, there might be some tax breaks there for them.
And what tax would that be?
Well, they would be paying,
We have no corporate tax.
we have no corporate tax. We pay taxes on our for-profit side of things.
Federal tax.
Okay, then I'm way off base. Sorry, Mr. Chairman.
And they may have paid on tangible property within their offices, but we eliminated all of that as well. So no one pays anything ever to the state.
I deeply regret
But that-
offering tax credits.
but
Sorry.
But Mr. Boley, yeah, but Mr. Boley, I think that's really important for the task force to remember, because as we think of these incentives, it's easy to get, because that is a common incentive, some sort of tax deduction, and most other states have them. But we just have to keep reminding ourselves that we don't have that. So then what incentives can we give them to replace that if it's not a tax break? And then you could say, well, we give them a property tax break, and our schools and our counties really hate it when the legislature does that because we're flirting with their revenue and less with ours. And so, let's not forget Wyoming's tax structures. We have those conversations. Okay, good. Thank you. Oh, Rob, please.
Thank you, Mr. Chairman. Going back to a point you made about the retention for some of these programs and the incentive. If your numbers are right, somewhere in the 40% range is what we're actually retaining. Why is it that we're not retaining more compared to those other states? Why is it, and can we get to the root of that problem? Number one, I'll start there. Do you see anything that we can do to increase that retention rate?
Mr. Chairman, I'm going to start sounding a little like a broken record, but I would say we have the great pleasure of supporting one of the best medical school programs in the country, in that we fund our graduates to go to a #1 medical school. When you graduate, when you're the cream of the crop, and then you go to a prestigious institution like the University of Washington, you're going to match with a really, really great residency also. And the temptation to go into a specialty or a subspecialty is pretty severe. The opportunity for our graduates to go into subspecialties is great. We have we're training incredible physicians, and we should be really proud of that. Wyoming does not have the volume to support those specialties and subspecialties. One of my favorite people who graduated from WWAMI early went into pediatric pulmonology. He's a phenomenal physician. there aren't enough, thankfully, there aren't enough children in Wyoming to support one pediatric pulmonologist. It's just not realistic. And so I think in some ways, we just have a math problem, which you've heard now for 4 days, I guess, about just the math, right? We don't have enough volume to support those. And so of the 20 students that we educate through WWAMI every year, only a portion of those are ever going to be eligible to come back to the state just by nature of the specialties that they're going to be best suited to. And so then when you take that number, which is going to be primary care and some of your specialties that are available to be practiced here in the state, then you have to find those jobs for them here, and you have to find the community and something for their spouse. And you have all of the normal recruitment problems that any other state does. We're incredibly rural. We have a little bit of an unforgiving landscape. Our graduates are falling in love with and marrying other professionals where it's hard to find them a job. I mean, we can talk about recruitment for a really long time in terms of all of the factors that contribute to making it so hard in this state. But I don't know that I have an easy answer for you. Some of those aren't necessarily fixable problems.
First off, speaking of falling in love, Becky and I celebrated 47 years last Sunday.
Happy anniversary.
Big deal for us. But Representative Garner, that's what attracted us to the University of Utah. To Sheila's point on family practice, family medicine is what we go into at WWAMI, and we do see a lot of diversification naturally happen. But the University of Utah is a rural health focus on primary care that we think gives additional focus on that discipline that we thought was worth funding as well. And so that's one of the efforts we're trying to make.
Follow up,
Please.
go ahead.
Well, no, I was just going to talk a little bit about residency and that component that plays in recruiting physicians here. It's something that my friends who hang out with me on the Labor Health Committee hear about quite a bit. So I'll repeat it. I'm sure they'll be really happy about it. But I think the other challenge that we have with graduating these really impressive medical school graduates is then they have to match with a residency. And even a primary care residency, if it doesn't have a focus on rural care, they sometimes train in a very different environment that then they're asked to practice in our state. And so Wyoming, with our family medicine residency program, we really are one of the few states in the country that have that in relation to all the residencies that are in more densely populated areas. Sometimes it's best to just make a point through a story. And so this one will be brief, but years ago we had a pediatrician graduate through WWAMI, matched with a very prestigious pediatric residency, was excited to come back to the state, but everything was lined up perfectly. Trained in a very prestigious residency in a really densely populated area with a children's hospital. So their skill set was really wonderful, except that in those interviews with our rural hospitals, when the question came up about who intubates a newborn, they said, well, you. And their training had been at a children's hospital where there is a team of people who just intubate newborns. And there's a team of people who just, make the list, whatever it is, and pick your specialty. When you're in a densely populated area in some of those big hospitals, you're directing care, you're overseeing care, but there are people who specialize in just individual nuanced things. And practicing medicine in rural Wyoming when you're the only one, and there isn't a backup team and there's nobody to call, can be a wildly intimidating endeavor. So much so that we lost a really wonderful pediatrician because they ultimately made the decision that that wasn't where they were comfortable practicing. It's not how they had trained. And so and so I think that's a challenge. I think underscoring the importance of our rural residencies and keeping them strong and continuing to support them. I can't stress enough how important that is, because we have to train physicians in the environment in which we want them to ultimately practice.
So I guess in that I appreciate that. That does make sense, and having the kind of training that is more specific to Wyoming. And I think some of it also goes back to you pointed out the more targeted approach, and data helps fill in the holes. Where is it in Wyoming that we have the need, and should we incentivize those particular areas, whether it's through a loan repayment program at a greater rate than other areas of Wyoming that don't have the need? Is it increasing? We're at 75% of tuition for the WWAMI program. Is that right? Do we increase that if they go to a certain area of Wyoming? You know, should we be looking at a more targeted approach? Because in Cheyenne, obviously, we've got a large hospital for Wyoming, with also access along the Front Range to a lot of the specialties that we might need, versus somewhere in the middle of the state that doesn't have that kind of proximity. So should we be looking at that kind of geographic targeted kind of program?
Mr. Chairman, yes, I think it's possible. And the pay gap is just as severe here in Cheyenne as it is in Torrington when you look at the difference between what a family physician can look to make when they are facing paying off their loans, starting a family. You know, when they're at the point in their life when they're deciding what specialty to pursue, that pay gap is going to inherently play or at least be a factor in that decision. And so that pay gap is real in Cheyenne and Casper just as much as it is in the basin. And so I think we have to be focused on that and making changes in this state to address that pay gap that is growing if we want to keep care in our state. And then if I guess I would consider that the cake, and our cake has fallen apart a little bit, and we need to focus on the cake. Some of what you mentioned feels like frosting, and yes, frosting's great, but we've got to have a pretty good cake, and I think our cake's in trouble. Before our policy summit this summer, was mentioning to a couple of people that I feel like Wyoming is on a little bit of a superhighway toward a world in which, and I don't know if it's 10 years from now or if it's 15 years from now, but if we don't have really serious conversations like this one, particularly around primary care, we're headed to a place where our state patches and ships people and gets them out, but we aren't in a position to keep our people here. And we haven't built the exit ramp, and we haven't paved it. And I think that it's groups like this one and maybe a healthcare commission, or maybe it's something different, or none of those. But unless we really decide what we want the exit ramp to look like and where we want that road to go, if we don't do anything, that's where we're headed. And I don't think that's good for our people. I don't think it's what we ultimately want for our state.
Thank you, Mr. Chairman. I'm fascinated by this whole concept. I used to be a fan of Northern Exposure, and then take the kid out of the city and drop him in Alaska and say, you're stuck here for 2 years. And the only thing that made him stay was he developed relationships. And that's what a primary care is all about, relationships. I don't know if any of you have ever heard of an organization called Christian Halls, but this is a mentorship program where they take professionals already in whatever profession it may be, and they hook them up with college students, and that professional mentor. So if you're in nursing, then the professional mentor is going to be a nurse. Is there anything similar to that plugged into, probably more appropriately, the WICHE program, where these students that are going wherever they're going are paired up with maybe Wyoming professionals that are the kind of people we want them to emulate, and maybe they can develop a relationship and share some of that drive for why it's better to be in primary care in Basin, Wyoming than in Seattle.
So that was,
Curious.
Representative Pendergraft, that was one of the really appealing things about the University of Utah's rural health
Right.
track, because they put them in residencies, Fort Washakie, Thermopolis and have a mentor and have mentors there that are focused on that type of rural care to acclimate them to what they would expect in that model of professional delivery. And I think WWAMI also tries to do that in their residency programs. Is that not correct,
Is correct.
Sheila?
That is true.
So that's helpful, but we're waiting until residency. I'm talking about starting to mentor these kids as soon as they come out of high school.
And that's the other part of the Utah Rural Health is they will start in their program, they'll start coming into the high schools ahead of time, mentoring them on the value of a medical profession and serving back in your community. We really look not only in primary care, but also in psychology and those sorts of things. We're pretty excited. I wish Dr. Hawes was here right now. She could explain that better than I, but we're really excited about their pre-college, pre-bachelor exposure to what the potential might be. Time will
Mr.
tell, right? Time will tell.
Yeah, because Mr. Chairman, as soon as they get down, they may not even understand all the options that are out there. And they get into a university and they start hearing about, oh, I could do this, I could go do this. We need somebody there. Yeah, you could go do that, but anyway, I'm glad to hear that about.
Mr. Chairman, we do have a variety of programs that are doing, I think, exactly what you're asking for. So WWAMI specifically, our clinical dean, Dr. Rob Munger, has traveled the state and spoken to almost, I don't even know how many high schools he's at. He's really proud of it. He enjoys doing it. Just going into high school auditoriums and having any student who might have an interest in healthcare at all go to the auditorium and listen to a doctor talk about WWAMI, talk about the opportunity. There's a lot of misperception among students that you can't go to medical school unless your dad's a doctor. They think it's just not feasible. It's a very unattainable, sort of mysterious place. And so he's traveled all of Wyoming talking to high school kids about how much the state has invested in them and how much of an opportunity there is for them to pursue medicine if that's what they want. Also within medical school, even in their first semester, they start doing preceptorships. And so they're rotated around a number of different specialties and they get exposed to working with physicians. In fact, several years ago, Mr. Boley will remember, and I don't remember the dates exactly, but probably 8 years ago, we had a severe shortage of emergency medicine physicians. And there was an emergency medicine doctor here in Cheyenne who was a beloved preceptor. Our medical school our medical students loved rotating with this physician. And it was evidenced by almost like imprinting. It was evidenced by the fact that the students that rotated through her ER, then when they went to graduate, a good number of them all matched emergency medicine, went to residency in emergency medicine, and then came out. And for the first time in a long time, Wyoming had more emergency medicine doctors than we had positions for in the state. And so I think that whole experience was pretty painful for those students because when they were in medical school, we had a severe shortage. And they were encouraged to pursue emergency medicine. They were matched with this incredible emergency medicine doc who loved every day of her job, did a really nice job, convinced them. They did 8 years later, they were ready to go, and we had nowhere to put them. And I think that's a really good lesson for all of us to keep in mind as we start talking about, manipulating how to incentivize or put, whether it's a carrot or a stick, when you start looking at medical training and trying to determine what specialty people pursue, I think it can get real dangerous real fast because where we have a shortage one place, by the time they're done training, just even at the beginning of being able to enter the workforce, 8 years later, it may be a different picture.
Thank you, Sheila. Great conversation. I think folks, we're to that point on reinsurance. I think we are going to take a 15-minute break and be back here at 2:45. And we're glad you made it, Commissioner Rude. We seen you run in and by the hair of your chinny chin chin. Thank you. Appreciate the effort. And we'll get talking about reinsurance options through the 1332 waiver of the Affordable Care Act. 2:45. Okay, folks, we're looking good. We're sliding in home, and probably one of the more important topics of the day when we consider what impacts we can have immediately or near term to impact insurance rates. And so understanding reinsurance is going to be really important, and what other states is doing. And so we've got, Libby prepared this memo that you've all read and are ready to get a clear definition. And then we'll ask the Insurance Commission to come up and talk to us about how or if or how we would implement a reinsurance waiver in Wyoming. So Libby, take it away, please. Please proceed.
Mr. Chairman, members of the task force, Libby Miles, Associate Research Analyst to the Legislative Service Office. As the chairman said, I prepared this research memo that gives a background on what reinsurance is under the ACA 1332 waiver, as well as surveyed states that the task force directed me on: Colorado, Idaho, and Montana. I will first go over reinsurance and then stand for any questions before going over what makes the surveyed states different.
And could we ask you, even before you go into the 1332 waiver, tell us what the waiver does?
Absolutely.
What is a waiver?
Mr. Chairman, members of the committee, under the Affordable Care Act, states can apply for waivers under certain provisions of the Affordable Care Act to make it so that they may be able to, they're called state innovation waivers. So the state has some flexibility to create ways that the individual market can still serve those goals, so the 10 essential benefits. So if you go to, if I just skip forward a little bit, on page 2, it lists out the requirements under a waiver. So they must provide the same services at or a more affordable rate than what is already provided under the Affordable Care Act without the waiver.
So would it be fair to me to say that they will let you take those government funds and expand the use of those funds to fund different similar services to different populations, but it can't be at an additional, it has to be cost neutral. You don't get any new money.
Correct, Mr. Chairman. So states may apply for waivers through the Centers for Medicare and Medicaid Services to create reinsurance programs. And before I go into that, I just want to set the expectation. So under the Affordable Care Act, the states receive subsidies known as premium tax credits, and these reduce the premiums of those eligible on the marketplace exchange. This comes into play a little bit. So since reinsurance programs offset high cost claims for insurers, providing individual market plans both on and off the exchange, thus reducing premiums for the entire individual market. Since these premiums are reduced, the federal government is required to spend less on those premium tax credit subsidies to keep the premiums on the marketplace at a reduced rate for those eligible. The savings of the federal government are instead turned over to the state, known as premium pass-through funds. So those on the exchange receiving premium tax credits don't necessarily see the reduction in premiums. Those on the individual market who are not receiving subsidies already do see the premium reduction. These pass-through funds are coupled with state-level funding for the reinsurance program and continue to keep premiums on the individual market low. It is important to note, again, like I said, those premium impacts are not necessarily felt by those already receiving the subsidies because the federal government is required to already keep those low premiums. It's those who are not receiving them. So the 400% plus, those who are no longer receiving those tax credits. Each state operates their reinsurance program through parameters. These parameters are set by calculating the program's overall funding level, both the amount of anticipated pass-through funding and state-level funding, and the rate of reductions that is sought in those premiums. The parameters include the attachment point, the cap, and the coinsurance rate. These definitions can be found on page 2, but I will also go over them. The attachment point is the minimum amount that an individual's total claims paid by the insurer must meet before eligibility of reimbursement from the program. The cap is the maximum dollar amount of claims eligible for reimbursement. And the coinsurance rate is the percentage of claim total that will be reimbursed between the attachment point and the cap.
Give us a real life example.
Mr. Chairman, you got it. So if an attachment point is $50,000, a cap is $100,000, and a co-insurance rate is 50%. These are just random numbers I came up with for an example. You would take the individual's total annual insurance claims and subtract the attachment point. So say an individual's total annual insurance claims was $70,000. You would take 50,000 out, so you're left over with 20,000. And you would multiply that by the co-insurance rate. So if it was 50%, the reimbursement to that insurer would be $10,000.
Thank you. Perfect.
Before I continue on to the surveyed states, is there any questions?
I don't want to confuse people, so.
Okay. Mr. Chairman, members of the task force, I'll briefly begin with Wyoming's history with reinsurance programs. So this begins on page 3 if you're following along in the memo. Wyoming does not currently have a reinsurance program, but there was an analysis done in 2018 to determine parameters for a potential program to be established in 2020. The study posed several parameter suggestions, assuming a $50 million funding level, with $40 million expected in pass-through funding and a reduction of 17% sought in premiums. These parameter suggestions can be found in Table 1 at the bottom of page 3. However, it's important to note that this was done prior to the effect of the individual mandate repeal as well as the American Rescue Plan Act. This study informed House Bill 85 in 2019, authorizing the application for a reinsurance program by the Department of Insurance. The bill proposed the program's state-level funding to come from a 1% assessment on health insurer premiums. The bill failed on third reading in the Senate. Yes, sir, Mr. Chairman.
When you say the study determined a funding level of $50 million, are you saying that that would require an infusion from the state of $50 million? What is it there you're saying?
Mr. Chairman, it assumed a $10 million funding level coming from the insurance premium assessment, that 1% assessment on premiums.
So take me back and help me understand what that a funding level of 50 million would balance the premium reduction. So is it going to take an increase of $50 million?
I'm sorry, Mr. Chairman, I'm not understanding.
Well, and that makes two of us, because I'm just not on in that paragraph. It says the study determined a funding level of 50 million would balance premium reduction with state funding from 1% assessment. So that's the state's portion. It doesn't matter where it gets it from, but that's the state's portion of 1% on the premiums. Oh, and then 40 million comes through pass-through funding. So then the state would have an increase in this model of $10 million that it receives through a 1% assessment on the premium.
Mr. Chairman, correct. However, I did just look at the fiscal note before this, and I think it estimated $9 million, but.
Close enough.
And I will happily defer to the Department of Insurance too, if they have any interjection.
Sure. Good. Please proceed.
An additional analysis was completed in 2021 to analyze the impacts of a reinsurance program on the 2023 individual market. The report estimated premium impacts, federal pass-through funding, and a needed state-level funding under a $25 million, $50 million, and $75 million funding level. And these can be found on Table 2 on page 4. And once again, with the grain of salt that this was prior to the sunset of the American Rescue Plan Act. Okay, moving on to the surveyed states, we begin with Colorado on the bottom of page 4. Colorado's current reinsurance program is approved through 2027. The program is the most complex out of the surveyed states, utilizing a 3-tiered approach. This structure applies a higher co-insurance rate, so an increased reimbursement to insurance companies for areas that have historically had higher premiums. Table 3 on page 5 and Figure 1 on page 6 provide information on the tiers and counties belonging to them. Table 4 on page 6 provides information on the parameters of the reinsurance program. And as you may note, all 3 tiers have the same attachment point and cap. However, the coinsurance rate increases, allowing for higher reimbursement. The recurring state level funding is provided through an annual health insurance premium fee. The fee is 1.15% of premiums collected by nonprofit carriers and 2.1% for for-profit carriers. 2.1% for for-profit carriers. For additional information regarding state level funding, please see pages 6 through 8. In 2024, Colorado's total reinsurance program spending was roughly $407 million. Of this, roughly $362 million came from pass-through funding and approximately $46 million from state-level funding. In 2024, the average statewide premium savings was 24.4%.
Please, Eric.
Just a quick question for you on the amount collected from the insurance companies. Are those only the insurance companies within the state that the Department of Insurance has authority over, or is that the national carriers as well?
Mr. Chairman, Mr. Boley, I believe it's not just those licensed, it's those domiciled within Colorado would be responsible for paying those insurance fees. Yeah. All right, moving on to Idaho on page 8. Idaho's reinsurance program is eligible through 2027. The program is both conditions and cost-based, meaning not only does the state have parameters dictating reimbursement, but the individual must be diagnosed with one or more high-risk medical conditions to be eligible. Idaho's reinsurance parameters can be found on page 9. The program's state-level funding is collected through a monthly reinsurance ceding premium paid by insurers and an annual 1.5% premium tax allotment of annual gross premiums. The 2025 annual state funding was reported to be roughly $23 million, while federal pass-through funding totaled roughly $149 million. The program estimates an 18% impact in 2026 individual market premiums. And lastly, moving on to Montana, beginning on page 9, the state's program is approved through 2029. The parameters can be found on page 10. The state funding is collected through a 1.2% assessment on health insurance premiums in the state. In 2024, the program reported state funding at roughly $11 million, with federal pass-through funding totaling roughly $30 million. Montana reported an average reinsurance impact of 10%. And lastly, Appendix A at the very back is a nice little visual comparison of the parameters of the programs as well as the average premium reduction in the most recent year recorded.
Would it be an assumption, because Idaho was like, they seen a premium drop of 12%, 18%, significantly higher than what we've seen in Montana. Is that because of the limitations imposed on the Idaho plan? Meaning that they have to have those existing conditions and then they've got a lower cap? Why the difference in the cost, the premium savings?
Mr. Chairman, it could be a multitude of things. It could be how their individual market's set up, but also, like you said, they're both conditions and cost-based, and I think that's what allows them to have a higher coinsurance rate at 75%, which is very considerable. It lowers those who are eligible. They have to be both conditions and cost eligible. Additionally, their funding level might be higher. Like we spoke about earlier, the funding level total will dictate how much the state is willing to set up the program and thus those parameters.
Thank you.
And Mr. Chairman, with the visual in Appendix A, that was my conclusion, and I'm happy to stand for any questions.
Questions? So I think the driver, as we consider, Madam Chairman, is what is the gain worth the effort here? And so if you can see a 18 to 20% reduction in your premium, I think it kind of raises your eyebrows and helps you get excited. 10% or lower is less so. And so I think as we contemplate that, the way you get lower premium rates then would be greater infusion of money from the state in addition to what we get through the federal pass-through. And so those are all things that we need to consider as Commissioner Rude comes up. So Libby, thank you. That gives us good background. Commissioner Rude, if you guys would come on up. So Libby, could you clarify a question? Senator Taft and I having a conversation. Did he understand you correctly? You're good there. Did he understand you correctly that $9 million infusion, that example that you used, would result in approximately an 18% reduction in premium? Or did that have ARPA dollars included in it?
That was from the 2018 analysis, so I don't believe it would have had ARPA dollars infused into it. But again, 2018, looking at the 2020 individual market, and that was done by the actuarial analysis paid for by the Department of Insurance by Wait.
So we would need to get an update on what that, right, which we'll probably be asking for. But you're right. Thank you. Commissioner Rude, we are really glad you're here. Thank you.
All right, Mr. Chairman, committee members, Commissioner Rude with Department of Insurance. With me is Ms. Ryan Keams, our Senior Health Policy Analyst, who is so aptly sitting in for me. Ms. Mills, that was really good. You might get a call from me should something open up in our office. I'm just saying that now. So I was going to just briefly touch on the 13. I couldn't explain it better than what you did when we were talking about reinsurance, but if you have questions, please let me know.
Can you get a little closer to your mic?
I was going to touch
Jeff?
base really on the process and what our experience was with it at the time and what some of the changes and problems and hurdles we face now. So she laid out a little bit of the statutory requirements that, the plan has to be just as comprehensive as the benefits. If the current ACA plan had 15 essential health benefits, that's what this one going forward has to have too. You can't cut what you're covering. The out-of-pocket limits and the premiums have to be just as good for the consumer. You must cover just as many consumers. And it must not increase the federal deficit at any point. The process, which is really the heart of the matter, in this case, you identify the problem, and most everybody has the same problem, and that is the cost of the premiums, the cost of care, and you develop the proposal, and in the vast majority of cases, the waivers involve a reinsurance, as we've discussed. The study that you get the ultimate plan going forward is really the key. The studies take between 12 and 18 months. They don't happen overnight. They look at the entire market and they analyze it, and they say how many people are on an affordable care plan, how many are on a short-term limited duration plan, how many have this care and this care, and what percentage of those would be benefited from this. Maybe we attract more folks with this. And they look at the rules that are applying to the ACA at the time of the plan. And I make that point because that's problematic if those rules change. All right. And so in 2018, when we pursued the waiver, we wanted as little general funds involved, if any, as we could. And we didn't have enough major medical carriers to assess. And so we included supplemental carriers. And that was an issue. So you have major medical, but we don't have as many major medicals as some of the other states. And so we had this other group of supplemental carriers. So people that might are health related. For example, if you have a limited plan that only pays for X number of dollars for hospital stays per day, or things like that. And because we needed more money to be infused. And that's what the study looks at. They come up with options and you kind of choose going forward what you want. At the time, the study cost, this is 2018, it cost $160,000. We were able to obtain grant funding for that. And so it didn't cost the state anything. I would probably submit a plan today is going to at least cost $250,000. It's probably, it's likely more than that, but you have to do that before you apply. And then you have to enact what they call enabling legislation. You have to not only have the study, you have to make your choice of how you want to proceed. And then you've got to go to the legislature and say, if you pass this, we are going forward. Then you apply. Because the federal government didn't want states backing out at the last minute and taking up their time and effort earlier in the process. So that process, now you're looking at 2 years, maybe 3 before something like this kicks in. So some of the problems.
Apologize, Commissioner Rude. So you have first step, enabling legislation. Second step is the study. Have I got that right, or we got them backwards?
Mr. Chairman, I believe we did a study, and then we went, I mean, we had the funding for the idea, and then we, like I said, we ended up paying with grants, but I think we did it. I think we went with enabling language that said, we're going to go forward with it now. This is the proposal. And that was ultimately not passed.
Okay, I'm just wanting to make sure that
Yeah.
the steps in order. So that leads to the year or 2
Mhm.
time frame required to actually get it into practice.
Correct. And looking back at it, one of the reasons it failed, and ultimately it was a good thing it failed, because the last thing that happened, I think it was in the Senate, was they stripped the other carriers. They only left major medical carriers. And the numbers wouldn't get us where we needed to go. I remember talking with the commissioner at the time. He says, this was a good thing that it did not go forward, because we would only be getting a 5%, if we're lucky, a 5% decrease.
Okay.
So some of our observations with the problem, talking with several states, even at the conference I was just at, every single one of them, I asked them a very simple question: does this reduce the cost of healthcare? And they all said no. It's just cost shifting. That doesn't mean they didn't like it, because of the group that we talked to. One state loved it, but they were a big state and they put in significant funds each year, $40 or $50 million. When I talked to a couple of the states that were similar to us, they had concerns or problems with some of the rules changing and the impact on it. So for example, when the study was done, short-term limited duration plans were capped at 90 days. And so they looked at them and they said, well, those people are going to want to come to this plan. This is a good thing for them. And since then, those short-term limited duration plan rules have changed maybe a half a dozen times since the ACA has been enacted. And that changes the underpinnings of the study that you're investing in, and that you're is the real architect of your program. I think, well, I talked to one state is actually leading it. They put in their notice. They said, we're no longer going to participate in this. You have to do that. It's a 2-year process.
Was that New York? Was that New York?
Yes, sir. And a couple other states, one state that's very similar to us demographically, said, we don't think as it is now, it's sustainable beyond 2 years. We're going to have to wait and see. And another state was just really upset with a lot of the changes of the rules and some of the pass-through funding being, the calculations changing. There's concern among the states of other things too. Like the major concern now is dealing with essential health benefits. The federal government is drafting rules that will possibly change how states are reimbursed for essential health benefits. So, the ACA comes out, there's 10 essential health benefits, they're all covered. If you want to do something additional in your state, and we've done this, the state pays for that for the first year. Then it's on the list of essential health benefits, and then the federal government was going to cover it. Well, now they're relooking at that. And some states have 20 essential health benefits, and they're looking to not pay for that and to shift that to the states. That's a huge problem with the 1332 waivers, because you still have to, unless you legislatively go in and take those essential benefits away yourself. They're not going to pay for them. And so we're pushing, the states we're pushing back on that with the federal government, saying that's not a proper interpretation. It quite likely could end up in court like many things do, and we'll see where the chips fall.
So in reading about New York, it sounded like they required a 1 or 2 year wind down before they let them exit. And I can't remember if that was in 27 or 29, something like that. It was an odd year that they're then able to be shuck of that reinsurance waiver. And that article noted that the program that they initiated when their waiver was approved kept moving, and the cost, it lost cost benefit and was costing the state. And I think you pointed that out as well, that that is a risk, that we don't control what those requirements are, and they could shift, boom, that to the state, which is really important for us to understand, that we could end up with a bigger piece of the enchilada than we really wanted to have. So to mitigate that, and we talked about this on the expansion population, when the government was paying 90% of the expansion, that we would draft legislation that said if they ever reduce that then we would no longer have that expansion. So is there the potential that if we move forward with this endeavor, that you could in statutes require that we come out if those conditions change? Would that be one of the belts or suspenders that you would maybe want to consider? And then if we did do that, folks, then you're Cruella de Vil, because then you've taken away those premium reductions that oftentimes, as Madam Chairman talked about earlier, the legislature doesn't like being the bad guy. So just, if I'm saying that right, I think that just important for the conversation.
No, Mr. Chairman, that's an excellent point. And we did try to do that with the belt and suspender approach, and that was the concern. I mean, do we really want what we're asking for if this should go south? I mean, are we really going to tell people? Now, that also could end up in court, because the federal government could say, well, our rules say 2 year wind down. Your statute, that conflicts with it. I mean, so once again, that could easily end up being litigated. But just a thought. I mean, one state I asked, I said, what are your thoughts on this? He says, we're rearranging the deck chairs on the Titanic, and we're cost shifting, and we're not doing anything to reduce the cost of healthcare. And that was their take.
And who is this?
I would rather not say on the record, sir, but once we're done today, I'll let you know.
Okay, it was another state.
Yes, it's somewhat similar in size.
Fair enough.
Than us. Yes. So, I think you can gather from our past experiences. Maybe I have a little, post-traumatic stress, but we don't look too fondly upon the process. In the sense, we're not really excited about it overall, but obviously if that's the way the legislature wants to go and look at it, we'll do that. There is some real difficulty, if almost impossibility, of just trying to take in what was done in 2018 and dusting off the numbers and coming back with a new chart. I mean, you have all new rules. Everything has changed since then. We would need a whole new study. We really would have any faith in it. And with that, I will sit for questions.
Mr. Boley, and I'd like, so this is a consideration that and you've heard this in the gubernatorial conversations, that, boy, we've got this reinsurance opportunity, and and so everybody, I'm hearing it from home, you're hearing it from home, what can we do? And now we're hearing some of the concerns that come into play, and to what degree would we like to move this forward or at all, for an October conversation, and to the point of maybe even beyond if that's required. So I would really like some guidance from the members of this force on how we do that. Eric, you got the floor, please.
Thank you, Mr. Chairman. Commissioner, just a question as far as the major medical carriers. Realizing that we have a very limited in-state licensure with Blue Cross Blue Shield mainly, and I think we could probably also attach Cigna with the employee health plan. Is there the ability to do anything with the other major carriers that insure lives here in our state but aren't headquartered here?
When we were doing assessments, it was all licensed major health carriers that were writing premium in the state, not just the ones domesticated here. So if a company is domesticated in Nebraska and they were writing a certain amount here, I mean, we collect premium taxes on anybody that writes business here. And so my understanding of what we did, what the legislation did was we were assessing on all of those, but that still wasn't enough. And that's why we brought in the supplemental carriers. And I guess another point too, and I don't want to put any, health companies on the spot either, but if I'm a health company and you now are assessing me more, that is a cost. That is a cost of my business. What am I going to do with that? It's going to show up somewhere, and it might just be in higher premiums. I mean, we're not just going to eat it.
So that was a question I had. Have you seen other states that generate that revenue other than a premium tax?
There's other, I know of no other state that also went after supplemental carriers. Where other states like Colorado can really get a little more traction is they have their own exchange. They control many levers here more so than we ever would, because that just how they've designed it. I know of no others, like I said, they did supplemental, but they do have increased state support.
So if I may, and I apologize to the legislators here that if you already know this, but when the affordable, I'm going to say it again just to educate, but when the Affordable Care Act come out and the idea of providing insurance through an exchange, you had a choice of doing a state exchange or having the federal government run the exchange. And we voted or elected to have the feds. We wanted to distance ourselves from the Affordable Care Act, and we've left it as a federal exchange. So those options or flexibility, however you want to choose that, from a state exchange, and like Colorado has, we do not have.
Yeah, Mr. Chairman, that is correct. The most difficult comparison is us to Colorado, just because.
Eric, please.
Mr. Chairman, I'm a little bit confused, and maybe you can help me understand this, but you're saying that you expect premiums to rise, but the studies show that premiums are lowered, maybe not for a long period of time, but the examples we have here show decreases in premiums. So I don't understand. I guess maybe if you could help me understand why you think that those premiums will rise, because the studies actually show that it's helped the insurers also after a period of time.
Floyd, I think, you can say we would have had a 20% increase. Now we have a 10% increase. Somewhere buried in there might be a 1 or a 2% increase that is built in with the higher costs of the insurance company now having to pay increased assessments. It doesn't mean that the consumer isn't paying less, because they are. I'm just saying that it's a cost shift. I've not seen something that shows all of a sudden the cost of providing this care, it went down. The premium might have went down, but I can't say the cost did.
Please.
So what would it look like to try and do a study to figure out what this looks like? Is that something that could be done by October to see if the juice is worth the squeeze, or how long would that take for you guys to put that together for us to take a look at
Mr.
it.
Chairman, Mr. Boley, we would not put it together. We would put together a proposal. We would farm it out to various vendors and we'd see what they would come back. I would guess it at a minimum, it'd be 12 months. And a minimum of 12 months and a cost of, as I said before, at least $250,000. Now, I don't have that ability. The legislature would have to give me the ability to increase my assessments in some way and build that into my budget. But that's what it would take. This is not something you can just dust off the figures and say the cost of bread went up here, but the cost of butter went down. We're going to plug it in. It's not that simple. All of the rules underpinning these studies have changed. All of them have.
This type of study would be just similar to the study that would be required to then make the application. So they need the same information that we need. We need that information to make a decision. And so if we were to move forward with this or make a recommendation to move forward, probably what we would be moving is the request for funding for the insurance commission to do a study to determine if the cost, the premium reductions would be worth the effort of the application. Am I saying that right, Commissioner Rude?
Yes.
So I think that's the direction that we would see this task force going this year, because we would do that in January at the session, right?
So as I think about the study, Mr. Chairman, thank you. As I think about the study, when you make an application, nobody's actually accepted that. Wouldn't it be just faster to make the application and see the results that come back that are real?
Mr. Chairman, yeah, the rules at CMS state that you have to have enabling language, and you've got to have a proposal that they can look at the numbers and ensure all of those things. No, increasing of the federal deficit. We have to look to see are all of the people that were covered, are at least as many covered before? Are you covering all of these other, and then you only get through that through the study.
So I think, and we need to set logic aside here. Yeah, well, I think what we're saying is, gee, we would like to know back from the CMS, if that's who reviews it. I don't know who reviews it, but if the waiver, if our proposal would work and the cost, they're saying we don't want to take on that burden unless we know you're serious about it. And if you're serious about it, show us the enabling legislation so that you're not going to back out, and provide us the information, and the information requires a study. So we're limited by their review, which requires the study and the enabling legislation. So I think we would, if we didn't want to we wouldn't have to do the enabling legislation in this legislative session. You could just fund the study. And if you liked that, then you could come back the following year and do the enabling legislation. Having the enabling legislation doesn't cost you anything. You could do that. Doesn't require you to move forward. It just enables you to. You get the information back, then you could see if the squeeze is worth the juice, right?
Yes, sir.
But it's probably a 1 year or 2 year. So Representative Pendergraft, please.
Thank you, Mr. Chairman. I went back and looking at this last page of the information given to us on reinsurance. Colorado has 6 million people. Idaho has 2 million. Montana has 1.1 million. We've got 600,000. Is there a correlation between the population and the percentage numbers in the bottom of that by any chance? And if so, the lack of population seems to create a diminishing returns, but I may not be.
Yeah, Mr. Chairman, Representative Pendergraft, I'm not, I couldn't say for certain, but I think that is part of the analysis of numbers. I mean, how many are on the exchange? And how many do we think will it increase? Because it needs to increase for this to go forward. And so they bring in the pass-through money. And do we think that that group is healthier or less healthier than the group that's already there? Because that affects, and they're based on their income, that can affect, the cost of the whole program. But there is, I mean, the states that have liked this, they put a lot of money into it, but they're significantly bigger than we are. Significantly larger than we are the states that really give two thumbs up to a 1332 waiver. But they don't blink an eye at putting in 40 or 50, $60 million. So.
Mr. Chairman, Commissioner, I understand some of the comments you've made. This committee, I thought we were put together to look at affordability. If we can lower premiums, that makes it more affordable for the consumers, understanding that there is a cost issue that we have discussed at length and will continue to discuss and work on solutions to. I don't see the downside if we can reduce premiums to the consumers for a period of time while we continue to work on the cost side of things.
So here's where I think that we need to gently walk through the stinging nettle. Okay, is that first off, of the thing that gets me attention is if New York's backing out. If there's one state that's going to take advantage of a federal program, historically New York's done that, and so that's just dust on the horizon. Okay, that says we probably ought to be careful. But I think the thing that you really have to consider is the ongoing changes within the system or the program that then you have to comply with. Okay, that should catch our attention a little bit. And then we're going into the last 2 years of an administration, right? And what are the potential changes that could come in? I agree, we don't know. And so if it takes us, we could argue that it's going to take us 2 years and we go in with a plan. And then within that new administration, whomever that may be, what changes would they be made there? And would that then change place a greater burden, maybe is the right way to say it, on the state? And I think those are the things that we need to consider that really could potentially, so if we're looking for immediate change within 6 months or a year, that probably isn't going to happen. So my crystal ball doesn't work good. And I'm not saying that you're wrong, but I'm saying that those are the concerns that I think give people pause. I don't mean to speak for everybody, but
Mr. Chairman,
me pause.
I disagree with you. On the flip side, 2 years, we could see changes that are even more favorable too. And you're right, the crystal ball. And when's the timing right, I guess, is the question. I don't know if moving forward with the study or trying to see what it looks like, what the benefit, what the squeeze or the juice, either one of them look like. I don't know if that hurts us until we actually sign on the dotted line. I realizing there's a cost to that.
So I think one of the things that you could move forward that really doesn't impact us, at least as we get ready in October, is to get an idea of what a study would cost, so that then we could consider whether we want to make that approach in January. So could we, on the cost of a study. So anybody have any angst with that? And then I think in February or in October, then the question before us in October will be, do we make this recommendation? And you'll be seeing hearings coming up in November or December for supplemental budget? December for supplemental budget. So we would have time to make that recommendation to the Appropriations Committee if we wanted to at that time. Okay,
Mr. Chairman,
please.
I'm actually trying to be helpful here and not.
You are.
Yeah,
Yeah,
but I would like to maybe hear from the insurers, what their thoughts are on this. I don't know if you have a feel or
Yeah.
an idea on this.
Please, Rocky. I couldn't agree more.
Mr. Chairman, Mr. Boley, we have one of our actuaries, Sean, who's joined us today. We've talked to Oliver Wyman, who we use for some actuary analysis. We haven't really put any extreme amount of coal in this because it does come at a cost. I mean, if we're going to do an analysis on this, it's going to come at a cost. And that cost, of course, is from the collection of premiums. And so we've been kind of holding off on the analysis. I think that we want to be helpful in this too. The one thing I'll say, and I think you already said it, Mr. Chairman, is that if we move forward with a reinsurance program that reduces premiums by 10%, and the premiums the year before went up 10% and resulted in folks leaving the market, the juice probably isn't worth the squeeze on something like that, because you're talking about people that have already left the market, that have already exited the market the year before. And what you're going to do is you're going to reduce premiums in the next year, but you're also going to have a built-in premium increase for that next year too. So that reduction will be completely offset by, or not, it depends on what the premium increase would be. But I think the commissioner stated it, and we've stated it many times, that this does not result in a reduction of the cost of healthcare. And so as healthcare continues to go up, premiums do too. And if we find a mechanism that can sort of offset that, it's not going to stop the rise. And if anything, it could potentially lead to, a softening of the blow, and then maybe a loss of focus on the fact that we still need to reduce the overall cost. But we want to help, and absolutely.
Well, and I, in addition to that, one of the things that, we use the Department of Health and the Hospital Association and the Blue Cross and Blue Shield like borrowed mules, and we try to get everything we can out of them for free. And I want to be real careful that we don't snuggle up to Rocky and say, gee, you got your actuaries. Couldn't they kind of preempt us on this study? I think if the state's serious about it, that's our responsibility, and that's something we should pay for. And because they're going to be getting slapped with the tax if we move forward with this. So, Commissioner Rude.
Mr. Chairman, we have vendors under contract that are there for a number of reasons that we use in the case of, for example, if we needed to look at a particular targeted exam of a insurer, we can run this by them. And if they can just give us some general cost parameters, if that's useful to you, that won't cost you anything, and we can make some phone calls and we'll see what we can come back with. Of interest, of note is when I first worked for the department, I was a senior policy health analyst, and they started talking about waivers, and no one had done them yet, and everybody was looking at them. And several folks in the room looked at each other and they said, well, why doesn't the federal government just have a national reinsurance program then, if it's such a wonderful thing? And that never went anywhere, but that was part of the discussion. If it's such a cost savings measure, why don't they do it and make it part of the program and help everybody out?
That's well said. Okay. Representative Pendergraft, please.
Thank you, Mr. Chairman. I may be way off base here, but I'm just sitting here thinking reinsurance, it seems to me, just adds one more layer of security to a provider to know that whatever they charge is going to be paid. There's a kind of a presumption there that to me moves away from the free market. And I don't see how it does save, in that all we're doing is making sure that whatever gets charged is going to get paid, and we're shifting the burden from one to another. Maybe you see a flaw in my thinking. You probably do. If so, I'd like to hear it. But I almost feel like this is counterproductive to what we're actually trying to do to reduce cost by making positive that whatever cost is out there is going to get paid without downward pressure.
So Representative Pendergraph, I think there's two things that we're wrestling with right now. One is how do you reduce the cost of premium? And then the other conversation that this has led us to another conversation is how do you reduce the costs overall? So two different kind of industries, and we would suggest that if we could lower medical costs, that would lower in premium costs. If we can't lower medical costs, then this reinsurance would come in and doesn't impact the ever increasing growth. It would reduce premiums. We're not saying that it impacts the costs at all. It just reduces the impacts of the premium on the people, and it's a policy decision. And you're right. It doesn't cure the end all, and I think that's what Rocky was referring to and did the first day. And I think what Eric is trying to say is fair enough. We've got this cost issue that we're looking at long term, but can we provide some help in the near term until that gets resolved? So
I get that. But my impression is that this actually exacerbates the problem in that it puts even more upward pressure on the cost itself, not the price of the premium. By shifting the burden, if you shift the burden from someone who's paying for the insurance to the general public at large, you distribute it farther and there's less pressure to keep it from rising. And my reaction is that this is counterproductive to the overall goal. And that's why I'm resistant.
Thank you, Representative Pendergraph, and also Mr. Boley. I don't know if it's just because of my job as an attorney that sometimes I come across a little fatalistic on things, and I apologize for that. But but what I will say is, we will be helpful in this situation. And I think that trying to find solutions for Wyoming specifically, and I think we've done a very good job at looking at some other states. And if we can find a way to reduce premiums in a meaningful way, then we would be able to help support that. And I think some of the things, sorry, Mr. Chairman, you probably want me to stop talking, and I get it, and I will if you want me to. But the one thing I'd say is, I definitely don't know that we want to follow the blueprint of Colorado, but there are some things there that I think are really interesting in that there's additional assessments that can be made so that we can all work together on this. There's also, as you can see from the findings, that there's a significant amount of additional premium reduction that comes from using additional mechanisms as opposed to just something that's very straightforward, overly simplified. And so if we can use some of those in the study to have that tested to see if it would be helpful in Wyoming and give it to somebody that is sort of not a Blue Cross employee or somebody that works for Blue Cross, but a third party that's neutral in looking at it, I think it'd be helpful to see.
So I think that brings us back to the value of at least understanding what the cost of, and if you could reach out and at least get some preliminary stuff and let's see what a cost, see what a study would be, but anything you could get us ahead of that time. And we understand it's not to the detail that the study would be, but just kind of a roadmap or an idea. And I don't think I would ask if possible, if you get it before the October meeting, the sooner we could get that, it kind of helps us to digest it and understand and talk in between the meetings on the value of the information and what conversations we'd have in the next task force would be.
Mr.
Please.
Chairman, yes, we will certainly do that. We will reach out to the vendors that we use, and we can talk to some other states. Maybe you've done this more recently and ask the states what it costs them. But we will do our best to get you something there.
Okay. Senator Taft, then Karen.
Mr. Chairman, thank you. So earlier you were talking about the ACA. They have essentially 10 things that they were covering on there, and states, used as a broad term, have added additional things to that. Do you know exactly what Wyoming has added to that? Are we talking we've added one thing, we've added nothing, we've added 25 things?
Mr. Chairman, Senator Love, we covered enzymatic disorder. It was a condition where a very small group of people needed to have special nutrition, and it was costly, and so that was passed. And so the next year the state paid for that increase. And then it went on as an essential health benefit going forward that the federal government paid for. Now, I will have to say that once you make something an essential health benefit, new products come out that are more expensive that fit that category. So in this instance, we had a known product, we had the known cost. And I don't recall the exact figures we talked about. But as soon as there was a guarantee of coverage, there was a newer products, and they were better. They were better to digest. They tasted better for the individual, things that are important, but the cost was exponentially high. And that's what you're left with. I mean, when you start to guarantee payment, innovation occurs in that field, in that space.
Please go ahead.
Mr. Chairman, thank you. So when you're looking at the costs that the chairman was just asking for a second ago, is there any way you could try to put a dollar figure with that in case that is shifted back to the state, if that's our one exception?
Mr. Chairman, Senator Love, I might have a conversation with Mr. Red about that because ultimately you see the pass through of that. I know initially what it was 10 years ago. I have no idea what it is now, but we can look. Maybe we can come up with something. We'll try.
Thank you.
Karen?
Thank you, Mr. Chairman. If I need to have my perspective enlightened, I'm happy to hear that. I'd like to go ahead and echo what I believe Representative Pendergraft is getting to. I also feel like this is an added layer. The way I understand the reinsurance is if I'm collecting sufficient premium to cover my claims, good job on me. If I want to shift the risk to another insurance company who I now have to pay premium to, if I have a really great year, awesome. But I paid this premium out for not a whole lot. If I had a really bad year and a lot of people in that high category of needing the reinsurance, my premium's going to go up because of utilization. So on top of the fact that what the commissioner indicated or was alluding to, I think, is that there is still going to be some pass through. So if the carriers have to pay a fee into it, my admin fee is going to go up. It's going to be passed through. It's not going to be free. They're not going to just eat it. And so between fees potentially going up because of the carriers having to pay it, again, I'm re-echoing the fact that it doesn't necessarily change healthcare cost. It's putting more expectation on the insurance to pay in and then pay again on premium for a reinsurance policy. So, and maybe that's not the case with the state reinsurance versus I go out and get a vendor stop loss program, but it's just shifting risk, which the insurance company still has to pay for. So just a thought.
Discussion. And I think we'll wait and we'll get this information. We'll continue this conversation in October. Okay. Thank you. That's very helpful. Appreciate your assistance. I think I would just follow up and say, we've heard this through this election season as healthcare has been a conversation. And so I think you're going to go back and you're going to have colleagues and new administration people be all excited to come in and wave the magic wand and reduce the cost of insurance. And I think you having this information that's been provided can really help guide that conversation in a realistic manner. So I hope. Okay, I think, were we at public comment? Let me. Larissa, do we have folks online? Okay, do we have anyone here that would like to? Please come join us, and if you would identify yourself and tell us who you are. Marguerite, good to see you.
Good afternoon, committee. I'm Jen Davis. I'm the executive director of the Wyoming Primary Care Association. I just wanted to share a little bit of context around, sorry, excuse me.
Jen?
Yes.
It's so good to see you.
Well, thank you.
I didn't recognize,
see
you
you.
got a new hairdo.
I did, yes.
And I apologize for not recognizing you.
No
We
worry.
worked very closely. My apologies. And thank you for being here. It's wonderful to have you.
Well, thank you. It's good to see you too.
Yeah.
I just wanted to share a little bit of context around primary care from the discussion earlier that Mrs. Bush talked about, and just add a little bit more from the perspective of the federally qualified health centers, also referred to as the community health centers. As we look at primary care, this program that the FQHCs are under is a federal program. It's been around for over 50 years. It's very successful. Thanks to the legislature and Department of Health and the governor's office put a significant amount to support that of RHT funds, but just wanted to let you all know a little bit more about where the benefit sits in there, because I think there's a lot that we can look at in primary care to replicate out of that model that really is a cost savings, that we can think about how to do that in a meaningful way. So the federally qualified health centers receive funding from the federal government that comes in the form of kind of per se like a block grant. They get a specific amount of funding each year to provide services, which is designed to serve the uninsured and the underinsured. So with those funds, they are required to offer comprehensive care, meaning that they have to have medical services, behavioral health services, dental, maternal, and pharmacy. All of those things need to either be on site or they have to have a direct agreement with a provider who provides that for their patients outside of their walls if they can't deliver it. So it's really about comprehensive care and looking at whole person care. Additionally, they have to provide case management. So that is what part of the block grant funding is for the case management component of it. And then for treating those who are uninsured or underinsured that they are required to see on the sliding fee scale. So sometimes there's a misconception that these clinics are free clinics. They are not free clinics. There is a cost to the individuals who access care there based on their income on the sliding fee scale. Well, as you can imagine, that of course doesn't cover costs. And so that's why it's supplemented through the government to be able to do that. So it's also really important that these clinics also, being a safety net provider, they still can serve anybody, but they need to ensure that they have a good payer mix. Otherwise, they're not viable to be able to afford to pay physicians, as you heard earlier today, of what those wages are. Most of these clinics have NPs or PAs in them just because they typically can't compete in the market for physicians. So as we look at that, in Wyoming, we serve about 1 in 13 patients, residents, of Wyoming, and we're serving right now around 43,000 patients across the state. We have 18 site locations currently, and with the RHT funding, we're hoping to probably add 4 to 5 new locations around the state to have some clinic sites. Some of these clinics are very small. Like we have a clinic in Lovell, we have a clinic in Grable. They're only there part-time just because the volume is so low, but they are serving those communities in a very meaningful way. The other thing that I just wanted to, yeah, go ahead.
So if they have to provide all of those services, we talk about dental even, and so
Mhm.
in Lovell or Grable, then I would assume, and they're only PAs, then they've got to use local resources.
Chairman,
Right.
that is correct. So
And so that reimbursement model then to the local resources, is that at a discounted rate or a reduced rate, or because they'll be getting the same, be a piece of that funding that's provided for those services in that community. Am I understanding that right?
Chairman, you are. So in many of those clinics, many of our clinics don't have dental on site just because there is such a significant shortage of dentists in Wyoming. So many of them don't have those services on site, and they contract with a local dentist to provide those services for them. When the dentist contracts with them, they have to agree to also serve those patients on the sliding fee scale as well. So that it becomes affordable for the patients who don't have dental insurance. There is also statute in Wyoming for the dental hygiene scope of practice through community hygiene, where they can actually see patients under the current law without a dentist being present. And that's only afforded in some of these areas for community health centers, school-based services, so that you can get hygiene services out there without having to have a dentist in it. And so the centers qualify for that as well. The other thing that's really important that I wanted to just briefly mention is the question that came up earlier, and I can't remember who asked it about, actually, I think it was you, Chairman, about mental health within these facilities. So these facilities are required to address behavioral health within their facilities, serve those individuals on the sliding fee scale if necessary. But they also are required to look at what's called integrated behavioral health or primary care behavioral health, meaning that especially due to the shortage of behavioral health providers, you really upskill your primary provider, whether it be a physician, an NP, a PA, to really be able to address those low-level mental health issues and serve that client. And so that it frees up your mental health providers to actually do the in-depth services that are needed. And so our clinics are engaged in some pilot models with that right now for primary care behavioral health integration. And that is a push from the federal government. So looking at how we, again, are really looking at comprehensive care and getting people kind of a one-stop shop instead of having to go here for one thing and here for another. And then the last thing that two things that else I want to mention, it also came up earlier about high school students. And I just wanted to mention Wyoming is currently in the development of creating a HOSA, which is a Health Occupation Students of America for future healthcare professionals. And it is targeted at high school students to really help them understand what the opportunities are. So the good news is that is being established in Wyoming right now. So we will have some opportunity to do that with a little bit more intent. And last thing that I want to mention, because I know you all are very tired and want to go home, is that when we look at these clinics and how we can support what we're trying to accomplish by lowering costs, increasing access. We also have programs within them that have the residency program. So our UW residency program in Cheyenne and Casper are both federally qualified health centers. So by doing that and placing residents in those rural locations, you open up the opportunity to train them in that rural healthcare setting. And the hope is that we continue to look at residents and put them in more of our rural site locations, because then those individuals are also eligible for student loan repayment through the federal government. To access that for loan repayment if they work in and guarantee time back in those qualification areas that are designated by the feds as a HPSA designation, a healthcare professional shortage area, which all of our clinics have to be in order to qualify for the federal funding. So just wanted to give a little bit of information there that I think there's some things we can really look at that really add a lot to primary care in Wyoming that really has some opportunities that we can think about. And you already have a statute that helps support this. It's 92127 that was created in 2021 to establish the primary care account that allows, there's no funding in it right now, but it does allow for capital construction, startup costs and equipment. And we could think creatively about how you could do base funding in that to create more opportunity if that's something that we want to think about in the future as well. So with that, I will stand for any questions.
Questions for Jen? I may have an assignment for you for October. I'll visit with you.
Okay.
Thank you.
All right. Thank you, Chairman. Thank you, committee.
If you'll accept. Yeah, go ahead.
Mr. Chairman, before my former colleague and current colleague, I would say, Jen leaves the stand, I just want to thank her and her members from the federally qualified health centers for their help and helping us develop the rural health transformation concepts. Some tough discussions, some good back and forth, but ultimately I think we landed in a good place. So thank you, and please pass along that gratitude to your members.
Chairman, Director Johansson, thank you very much. We appreciate being thought of, so thank you.
Thank you. Ms. Herman?
Thank you, Mr. Chairman. Marguerite Herman, I'm sitting here today as a member of the board, chairman of the board of Healthy Wyoming, which has been around for several years. It's a 501c3 that explores various ways to deal with policy, laws, and regulations and other efforts to make healthcare affordable and accessible in Wyoming, which is kind of a global statement. And I just want to mention that I'm very happy that the FQHC in Cheyenne HealthWorks is my medical home. So I'm using it. It's a great facility. And I appreciate all the services they do for everyone in the state. I was going to make 3 quick points. Since the subject area that you're tackling is near and dear to our core mission. Just 3 things. Number 1, thank you for taking this on. As has become abundantly clear, it's hugely complex problem, and it's just lots of causes, sources of information, and structural things, regulations. It's just thank you for taking it on. It's I think you've got a great LSO staff. You've got wonderful people at the table, and you're approaching, I think, the right way with just trying to understand systems, getting data, and then just trying to figure out best way forward for Wyoming, which is, we're kind of unique. Number 2 is that what has become kind of clear, also abundantly clear, is that the meetings you've had so far, and then the meetings coming up, is actually more of kind of a scoping session. I think you're just getting everything on the table and looking at it and putting in its place. And what can we do? What should we do? What works? What doesn't work? And I would just suggest that after the meeting in October, perhaps it be suggested to Management Council or perhaps legislation for the next session of continuing this effort on. Next year, it may be an ongoing one of those task forces that have a very long-term task. And so I think you're getting a handle on some things that may show promise for our state. I would suggest it's going to take more than 1 more 2-day meeting to do that. And so I would suggest you keep on going. This has brought many, many people to tears, the whole topic. So I just applaud you for taking it on. I think you're doing it the right way. You're doing it thoroughly, responsibly, leaving all things open, considering all things. And apropos of that, my 3rd point is simply that, just to reiterate, please keep Medicaid expansion on the table as simply a thing that we have a lot of modeling and data that could ensure 19,000 people in Wyoming with a current program that's already proven itself to be efficient and to provide healthcare to people around the state. just keep it in the mix, along with the other things you're going to talk about. We think, it has a lot to offer, and as you consider ways that things are but they interrelate, interlock, Medicaid expansion, I think, is going to prove itself that. And I know that's all I have to say. And you've got a lot of work being prepared for October. It's going to be a busy meeting, and I look forward to it. And if there are any questions, I'm happy to answer.
Thank you. Thank you, Marguerite. Questions from the task force members? Thank you, Marguerite. Lindsay, please.
Mr. Chairman, members of the committee, Lindsay Semino, I'm the Executive Director of the Wyoming Behavioral Health Alliance. I just wanted to give you some information as far as work we've done behind the curtain, as well as echo a lot of Ms. Davis's statements today. Once the Rural Health Transformation Funds became a viable option for Wyoming, we very much worked with the Wyoming Primary Care Association and the Medical Society on what was already talked about, this integrative behavioral health care model. And so it's also a lot of what our initial proposals to the Department of Health were around when they were looking for, prioritized needs for the Rural Health Transformation Funds. With all that being said, whenever primary care is being discussed, we very much feel that behavioral health and mental health is part of that discussion because of these new federal guidelines when it comes to these clinics that we are having across the state. And with that, I don't need to repeat anything that Ms. Davis covered, so I will stand for questions.
Thank you. You've been a diligent participant for over the last couple of days. Thank you. Any questions for Lindsay? Thank you. I think we have former representative, good guy, friend, Patrick Sweeney online. There he is. I see him in front of the cowboy boot portrait. Can you hear us, Patrick?
Yes. Thank you, Mr. Chairman. Good afternoon. My name's Pat Sweeney from Casper. I'm representing myself. I belong to a lot of different organizations. One you heard from Marguerite, but I am not representing them. So, Mr. Chairman, I was unable to log on a lot of the time with some flooding in some of my properties yesterday, and I apologize for that. And I apologize in advance if you've already moved a bill. My main purpose is I was at a meeting earlier this year that Director Johansson kind of put a bug out there after the perpetuity fund was kind of eliminated. And so all I'd like to say is if there was a way forward, I think some sort of a trust account, and my belief is the legislation is already in place to possibly, if finances allow, and the legislature and the appropriations committee would allow, a 50 million request be put and started our own perpetuity fund for future use to carry things forward. That's my only request. I'm doing that on my own, and I think it's a great idea. It's unfortunate the federal government and CMS didn't allow the great idea of the perpetuity fund to carry forward, which would have been very unique and would have been awesome for Wyoming. You had the vision, Mr. Chairman, yourself, along with others, on our suicide hotline. And we're able to get, I believe it was 5 million passed in very rough waters in the 23 session, if I remember right. But I applaud that effort. We need more to stand that program up into the future. And this would be a great move for the future. Thanks for all of your hard work. What I was able to hear was very great discussions. So with that, one last final thought, Mr. Chairman. I didn't recognize Jen the first time I saw her earlier this year either. So don't feel bad, but she continues to do great work for the state. Thank you, Mr. Chairman.
Well, I'm sitting in a chair of embarrassment because I really do feel bad about that, Pat. And Pat, just to, on your note on a setting aside some sort of, or creating a corpus for sustainability of healthcare, this committee, which is really focusing on health insurance and how that ties into healthcare, have not considered establishing or making that recommendation. I do know, however, that that is being considered and evaluating possible sources for one-time funding for that. I don't, the concept is out there and very much alive, just trying to figure out how to bring it forth.
Thank you, Mr. Chairman.
Thank you.
And safe travels to you all. And again, thanks for your good work and good luck.
Thank you.
Next Tuesday.
Thank you. Any other public comment? None online? Any here? Okay. Thank you. Anna, do you want to public comment is closed? And if we could maybe just have a review of what you see the tasks are that we've set aside for October?
Shut it off.
All right, Mr. Chairman, so let's see. We're going to be looking at some sort of proposal where a company would work with the state to manufacture needed medical devices and equipment that contract would likely need to be held by the state. The non-compete bill draft was moved and is going to be sent to judiciary. We're going to be talking about somewhat of a public service commission model where hospitals are regulated as far as the prices that they're charging for services. We're just going to be having that discussion. We're going to write a letter to JAC regarding covering the entire cost of education for students in Wichita and Wyoming rather than funding them 1 year at a time or one biennium at a time. And then we're also going to get some numbers from the Department of Insurance regarding doing a study to see whether or not we should be dealing with a 1332 waiver. That's everything I have, and if I missed anything, I'd be happy to add it to my list.
Don't let us slip on having healthcare ministries make that request for them to be here. Madam Chairman, is there anything that you've got on your list that should? Okay.
No.
Committee members, task force members, thank you for your time. Have a good weekend. And we'll close the meeting. Thank you all. Did everybody get their per diem sheet?